This lecture is on mitral stenosis and pregnancy. The presence of mitral stenosis in a pregnant patient suddenly changes the spectrum of the disease. The disease suddenly flares up and the patient becomes critically ill. In the developing nations, pregnancy and mitral stenosis is a major cause of mortality associated with pregnancy. So let us discuss various aspects of this disease when associated with pregnancy. This lecture is on pregnancy with associated mitral stenosis. Mitral stenosis changes the course of pregnancy very dramatically. In fact, the presence of mitral stenosis makes it very difficult to continue pregnancy. In the developing nations, we commonly see patients with mitral stenosis getting pregnant and then landing into difficult clinical situations. As anesthesiologists, we have to face the situation regularly. Let us see how and what happens in pregnancy with mitral stenosis and how do we manage it. So anesthesia and analgesia aspects in pregnant patients with mitral stenosis. What are the lecture objectives? We have to understand the gravity of the problem. We have to understand why does mitral stenosis in pregnancy pose a serious problem. We have to understand the serious effects of pregnancy and the worsening of cardiac function in pregnancy due to mitral stenosis. We should know about the risk of pregnancy in patients with mitral stenosis, the aspects of anticoagulation to be used, anesthetic concerns in vaginal and cesarean delivery, and lastly, what all interventions are possible during pregnancy for mitral stenosis. As you know, valvular heart disease constitutes the majority of all cases of heart disease during pregnancy. Heart disease is considered as the most common cause of indirect maternal health in high-income countries. In lower-income countries, rheumatic heart disease is found in 60 to 80% of pregnant women with heart disease. And it is one of the major causes of death related to pregnancy. The incidence of heart disease in pregnant patients varies from 1 to 4%, and rheumatic mitral disease is the most common heart disease seen. Pregnant women present with increased pathological events such as congestive heart failure, arrhythmia, the need of initiating or increasing cardiac medication doses, and of course, they majorly increase the hospitalization costs. So what is the problem? The problem is that, the problem is that of hypervolemia, increase in heart rate and cardiac output, and anemia caused by pregnancy. All of these cause an imbalance of the cardiovascular system and decompensation. Thereby, it requires intervention or medication. Medical or interventional treatment indicated if the lesion is severe and the symptoms deteriorate, we need to intervene. Maternal mortality is low, but general anesthesia, cardiopulmonary bypass, and thoracotomy are definitely an increased risk for and can cause fetal mortality. As we all know, pregnancy significantly increases cardiac output. So maternal morbidity in form of congestive heart failure, atrial fibrillation, valve thrombosis, thromboembolism, bleeding complications, and non-functioning prosthetic valves are very common during pregnancy. So it's very important that patients with mitral stenosis are counseled for pregnancy, that is not to undergo pregnancy. And in case they do definitely get pregnant, there should be strict prenatal care and early risk stratification during gestation, which are fundamental measures to improve outcomes of pregnancy. Now, let us look at the physiological changes of pregnancy as they affect in mitral stenosis. The major adaptation in maternal anatomy, physiology, and metabolism required to ensure successful pregnancy actually are detrimental to patients who have cardiac involvement, especially mitral stenosis. Hormonal changes significantly alter maternal physiology, and these changes persist through both the pregnancy and also the initial postpartum period. There's an increase in the total body water of 6.5 to 8.5 liters by the end of gestation, which represents one of the major adaptations the body has for pregnancy. The additional water is accounted for by expansion of the blood volume. The blood volume expands by, it is said, by about 1.5 liters, out of which the plasma volume is 1200 ml and the RBC volume expands by just 400 ml. The remainder body water is attributed to extravascular fluid, intracellular fluid in the uterus, breast, and expanded adipose tissue. The condition of chronic volume overload with active sodium and water retention is secondary to changes in osmoregulation and in the RAAS system, renin, angiotensin, aldosterone system. The increase in body water content contributes to maternal weight gain, hemodilution, physiological anemia of pregnancy, and elevation of the maternal cardiac output. Inadequate plasma volume expansion has been said to be associated with increased risk of preeclampsia and fetal growth restriction. So it is very important that the pregnant lady does have water accumulation and increases the plasma volume to avoid the problems of pregnancy. In early pregnancy, there is a reduction in the systemic vascular resistance due to the gestational hormones and increased production of nitric oxide. And all this causes a decrease in the mean arterial pressure of the patient. Decreased mean arterial pressure activates adaptations to preserve intravascular volume by sodium retention. There is an increase in the plasma renin activity, angiotensinogen levels and angiotensin levels are increased. And this increase is said to be 4 to 5 times over the non-pregnant levels. As the circulating blood volume increases, the RBC mass increases correspondingly, but at a lesser rate than the increase in the plasma volume. And this results in what is called as the physiological anemia of pregnancy. This further contributes to a fall in the systemic vascular resistance and pulmonary vascular resistance, reducing the blood pressure in the first half of the pregnancy. Later on in pregnancy, the compression of the inferior vena cava can occur from the gravid uterus, which further decreases the venous return and eventually decreases the cardiac output further. These changes are well tolerated by normal hearts, but in mitral stenosis, heart failure may ensue as a result of the necessary hemodynamic adaptation of pregnancy and labor. In early pregnancy, mitral stenosis may become manifest due to early physiological changes which increase LA pressure. Symptoms of dyspnea and eventually tachypnea, orthopnea, and PND appear. Things which were not there in a patient, but they will certainly appear. Blood pressure in mitral stenosis is maintained by maintaining a high SVR. In a normal patient with mitral stenosis who is not pregnant, blood pressure is maintained by a high SVR. But this fall in SVR due to pregnancy causes a fall in the cardiac output. The fall of the gravid uterus over the IVC causes sudden reductions in preload to the heart, which may benefit a failing heart, but may not benefit a non-failing heart. However, the sudden removal of IVC compression at childbirth may cause severe pulmonary edema. Coming to vasoactive peptides, ANP, which is secreted by atrial myocytes in response to dilatation, is high in patients with pregnancy. Similarly, the levels of BNP which are secreted by ventricles in response to high end-diastolic pressure and volume, are also raised. Both these peptides have similar physiological action, acting as diuretics, natriuretics, vasorelaxants, and overall antagonists to RAS. The LV-EDV increases 12% over the preconception value in echocardiography. The LV wall mass increases by 52% and the atrial diameters increase bilaterally, peaking at 40% above the non-pregnant values. The pulmonary capillary wedge pressures are stable, reflecting a combination of a decreased pulmonary vascular resistance with an increase in the blood volume. So what are the risks in mitral stenosis? Mitral stenosis causes extreme disability and even mortality during pregnancy due to an increase in the transvalvular gradient and a rise in the LA pressure. Maternal mortality associated with mitral stenosis is stratified by the NYHA classification as under. In case the patient is class 1 symptoms, has class 1 symptoms, mortality is 0.1%, class 2 symptoms 0.5% or 0.3%, class 3 symptoms 5.5%, and class 4 symptoms 6%. A thing to remember is that most patients are class 1 or 2 at presentation, but become class 3 or 4, about 12 to 25% of them become class 3 or 4 by the time the pregnancy is proceeding to the third trimester. The development of atrial fibrillation may result in rapid decompensation. Digoxin and beta blockers can be used to reduce heart rate, and diuretics can be used to reduce blood volume and LA pressures gently. It's very important to control the rate to normalize the hemodynamics and allow adequate diastolic filling of the ventricles. Cardioversion can also be performed in case of an acute atrial fibrillation. Despite this, the maternal mortality rises by 5 to 10% in atrial fibrillation. What are the risks? The AHA risk classification of valvular heart lesion according to maternal fetal risk says that the patient has low maternal and fetal risk in case the patient has got mild to moderate mitral stenosis with an valve area of greater than 1.5 centimeters square, and the patient has a gradient less than 5 millimeters of mercury without severe pulmonary hypertension. The patient has a high maternal and fetal risk in case the mitral stenosis is functional class 2 or 3 or 4 as far as functional classification of mitral stenosis is concerned. And the patient has only high maternal risk in case the patient has got history of congestive heart failure, stroke, or TIA, while only neonatal risk is high in case the patient has got multiple gestations. Patients with greatly elevated pulmonary vascular resistance resulting from severe pulmonary hypertension, right heart failure, and cardiac output which is low are at high risk. Termination of pregnancy for health and survival of mother may require consideration, and should always be considered in patients with severe PAH. They should always consider termination of pregnancy. Mitral stenosis limits increase in cardiac output, which may cause further restriction of uteroplacental perfusion and intrauterine growth. Mitral stenosis is, as a result, associated with premature birth, low birth weight, and fetal mortality. In case of deterioration of conditions despite medical therapy, percutaneous or surgical intervention should be considered, and these interventions are PTMC, surgical valve repair, or MVR during pregnancy. What medical therapy can be tried? Medical treatment may relieve symptoms, but their effect is unpredictable. It might postpone surgery, but can result in causing hypoxemia with consequences which are adverse for the mother as well as the fetus. Medications have negative effects on the developing fetus, while interventions might relieve symptoms for a longer period of time. Interventions, however, have complications like systemic embolization, arrhythmia, premature uterine contraction, fetal distress, and fetal loss. Coming to cardiac output. Cardiac output significantly increases beginning in early pregnancy and peaks to 30 to 50% above preconception values by 25 to 30 weeks of gestation. Anatomic and functional changes on cardiac function reach a crescendo during labor. In women without epidural anesthesia, cardiac output between contraction further increases by 12% during the first stage of labor. What about patients who have got prostatic valves? Pregnancy increases the risk of thrombosis of the prostatic mechanical heart valve. The incidence of thromboembolic complications is said to be 7.1% in women with low molecular weight heparin therapy during the entire pregnancy. Despite this therapy, it's 7.1%. It is 3.6% in case patient is receiving LMWH during the first trimester and warfarin during the second and third trimesters. In case the patient receives 2.4%, patient receives warfarin all through the 9 months, the mortality incidence, the thromboembolic incidence goes down to 2.4%. So as you see, oral anticoagulants are the most effective way of preventing prostatic valve thrombosis, but the thing to remember is they've got severe adverse effects on the fetus, and that is why the second choice of having LMWH in the first trimester and warfarin thereafter is a more sensible choice. The incidence of warfarin embryopathy, that is abnormality of fetal bones and cartilage formation, is said to be 4 to 10%. The risk is highest when it is administered within 6 to 12 weeks of gestation, that is the first trimester. During the third and the second trimester, warfarin has been associated with fetal CNS abnormality, so it's not free even there. Warfarin freely crosses the placental barrier and can harm the fetus, but it is safe during breastfeeding. Oral anticoagulants. Warfarin during pregnancy in women with mechanical valves diminishes the risk of valve thrombosis, but is associated with a high level of fetus loss to the term of almost 30%. That is why, as I said earlier, it is admissible to use warfarin therapy during 2 periods. It is inadmissible to use warfarin during 2 periods, that is between 6 to 12 weeks of pregnancy and after 36 weeks of pregnancy, as it doubles the fetal mortality as compared to administration of heparin. So we have to change twice. Initially give low molecular weight heparin, and after 36 weeks again change over to low molecular weight heparin. During the second and third trimester, oral anticoagulants generally seem to be safe on the fetus. As far as heparin is concerned, non-fractionated heparin is harmless for the fetus. However, its administration is restricted to hospitalized patients. Though it's very safe for the patient, you need to hospitalize the patient all through the pregnancy in case you want to use non-fractionated heparin. Heparin during first trimester reduces the risk of maternal thromboembolism and death by half, but long-term administration is associated with heparin-induced thrombocytopenia and osteopenia. Within these periods, heparin should ideally be applied under monitoring of coagulation. If you use heparin, the dose is based on APTT values of 2 to 3 times the control value. High doses are often required to achieve this goal because the patient is hypercoagulable due to pregnancy. Parenteral infusion should be stopped 4 hours before cesarean sections, and heparin can be reversed with protamine sulfate in case it's an emergency cesarean section. LMWH can be used as the first option for anticoagulation. Substituting LMWH for warfarin during organogenesis reduces the risk of warfarin embryopathy but increases the risk of maternal thromboembolism because LMWH is not as efficient as heparin, non-fractionated, and oral anticoagulants for preventing thromboembolism. As per the American College of Chest Physicians, the strategy for anticoagulation should be such that during the first trimester, you should use either unfractionated heparin or low molecular heparin. During the second trimester, use warfarin, and during the third trimester, initially use maybe unfractionated heparin and later on use LMWH. That's their recommendation. If such a patient, that is a patient with mild to moderate mitral stenosis, comes from vaginal delivery, epidural analgesia is usually well tolerated, but it should be administered by a skilled operator. A single shot spinal anesthesia is a small dose of 1 ml of 0.25% bupropion with 10 to 20 micrograms of fentanyl or 0.1 to 0.2 milligram of morphine may be used by less experienced people. So if you are less experienced, it's better to go for a single shot low dose spinal anesthesia. If you are experienced, then you may try an epidural analgesia. Tachycardia, pain, anxiety, anemia, and forceful uterine contraction, however, are known to cause sudden hemodynamic collapse and they should be avoided. The American Heart Association no longer recommends antibiotic prophylaxis for prevention of bacterial endocarditis during genitourinary procedures such as vaginal delivery and cesarean section in high-risk patients. So, antibiotic prophylaxis is today not to be considered. As far as cesarean sections are concerned, graded epidural anesthesia should be performed using small increments of local anesthetic to achieve an adequate level, that is T8 and T10. I'm talking mild to moderate mitral stenosis, not for severe, okay? These patients are very sensitive to changes in preload and afterload, and fluid and vasopressor therapy must be very carefully titrated against blood pressure, especially in NYHA class 3 and class 4 patients. Small boluses of phenylephrine 50 micrograms are effective in avoiding precipitous hypotension. In many cases, elective cesarean section and a GA may be a better option. A brief period of postoperative ventilation may be required in some cases. In cases of advanced disease, invasive arterial monitoring is advisable. And in case the patient has got severe MS with severe symptoms, PA catheter should be advanced in such a case. And we should monitor the pulmonary artery wedge pressure. Combined spinal epidural anesthesia may have a role in experienced hands. Cesarean delivery requires a block up to T4 level, and spinal anesthesia is best avoided in such a case. So what you do in CSE is you give a small dose of spinal anesthesia and very gradually add fluid to the epidural space. And you should use fluid restriction, you should use diuretics, and supplemental oxygen benefits should be given to these patients. Bolus doses of oxytocin are contraindicated in view of the precipitous systemic hypotension it can cause and pulmonary hypertension which can be there. We may give small or maybe an infusion of oxytocin if required. In case the patient's condition deteriorates during pregnancy, the patient may require correction of the lesion or the intraoperative repair, operative repair and replacement of the valve or percutaneous mitral valvotomy before conception or during pregnancy. During pregnancy, percutaneous valvotomy is usually deferred to the second or third trimester to avoid fetal radiation exposure in the first trimester. So these are the therapeutic options. Pre-pregnancy, you can ask the patient, if the patient wants pregnancy, you can ask the patient to undergo a percutaneous balloon mitral valvotomy, or the patient must be put on ideal medical therapy so that the patient is asymptomatic, and in case the disease is mild in nature. During pregnancy, the patient will have to be shifted to maximum medical therapy, and in case the patient still remains symptomatic, then in the second trimester or maybe the end of second trimester, the patient can be taken up for balloon mitral valvotomy. In case such a patient comes for emergency surgery, mortality is said to be 1.5 to 5% for the mother and 16 to 33% for the fetus. And especially in case the patient undergoes cardiac surgery with cardiopulmonary bypass for a prosthetic valve dysfunction. A gestational age of less than 25 weeks is the predictor of fetal mortality. Pulseless circulation, activation of coagulation cascade and complement cascades, hypotension, hypothermia, and its inflammatory response results in the alteration of placental circulation during cardiopulmonary bypass. Open heart surgery under cardiopulmonary bypass must be undertaken only in extreme conditions. Emergency and redo operations carry even higher risks. CPB is associated with maternal mortality rate of 3 to 15%, which is similar to non-pregnant female. However, the fetal mortality is very high. It has remained at 20 to 33%, with the average of 19% over the past 25 years. That is, despite improvements in CPB technology, we have not been able to reduce the fetal mortality in case the patient is pregnant and undergoes mitral valve surgery. Open heart surgery should be avoided during the first trimester, and if it is not feasible, precautions must be taken. During cardiopulmonary bypass, normothermic bypass should be used with high flows and high pressures because that offers least risk to the fetus. Fetal heart and uterine monitoring should be used to allow adjustments to ensure adequate placental perfusion. If the fetus is more than 28-week gestation, it is safe to deliver the child immediately before at the same surgery. CPB, as I said earlier, should be normothermic, and you should maintain the acid-base balance. Perfusion pressures should be maintained greater than 70 millimeters of mercury. There should minimization of the duration of the aortic cross-clamp time and also have a short CPB run time to decrease fetal damages. Placental hypoperfusion leads to acidosis and subsequently fetal bradycardia, and fetal mortality of 24% in hypothermia and 0% in normothermia. Post-delivery care, the symptoms of congestive heart failure or moderate to severe MS may need close hemodynamic monitoring during labor, delivery, and postpartum. Optimized management during pregnancy and labor should be carried on into the puerperia. Majority of deaths occur in the postpartum period, so that is why intensive monitoring should be continued for at least 72 hours after delivery, preferably in a high care unit or in an ICU. Thank you very much.